Our first presentation features Dr. Teri Schreiner. Dr. Schreiner directs the Neuroimmunology Clinic for Children, a multidisciplinary clinic for the care of children and adolescents with MS. This clinic is staffed by a neuropsychologist, a psychologist, a social worker, Dr. Schreiner, a research coordinator, and a pediatric neurology nurse. She is going to help demystify the question of, am I immunocompromised on MS DMTs?
Hello, I'm Teri Schreiner, one of the physicians at the Rocky Mountain MS Center at Anschutz, and it's my privilege today to talk with you about our disease-modifying therapies and try to answer the question of, am I immunocompromised? Hopefully, I'll dispel some myths and share some of the subtleties in answering that question. So, the short answer to that short question is it depends. Risk with all of our disease modifying therapies is variable. It depends on the patient, it depends on the medicine, and a host of other factors that we'll talk through as well. So hopefully by the end of this, you'll be able to say more than just it depends. But that is the shortest answer, unfortunately, to that very simple question. So now an outline. So what I'll start with first is just a recap of what we know about the pathology of multiple sclerosis. How does it actually cause the disease? We'll learn more about how the immune system is involved because that feeds directly into our discussion about how our disease modifying therapies, or DMTs for short, how our medicines affect the immune system and how those mechanisms influence risk. After we get through that, I'll give some specific examples about risk with our medications, talking specifically about COVID because it's a big part of what we deal with in doctor-patient discussions and in life. We'll talk about something called progressive multifocal leukoencephalopathy, which we thankfully shorten to PML. That is a brain infection we'll talk about. And I'll give some real world data about risk of infection with some of our medications. So first, I hope you will allow me a simplistic rendering of our very, very complicated immune system. The job of our immune system is to keep us healthy, to fight off invaders, which in a healthy, normally functioning immune system can be things like viruses, bacteria. Those are the most common types of invaders, but can also be things like cancer cells. Our immune system actually plays a role there too. And this fight, this defense, lends itself pretty easily to a analogy of, castle defending invaders on horses. And this is the schematic that we have in front of us. Now, in this particular example, the cavalry with the brown on the left is our altered immune system causing MS problems. All of the other players on the right side of this cartoon represent elements of our immune system that are trying to keep us healthy. So they all have very fancy names, but we're going to call them flying dragons. We're going to talk about the cavalry in blue. We're going to talk about the cannons and, probably some infantrymen and lots of other things that we're not seeing right now. But these are all representative of the multiple facets of our immune system trying to keep us healthy. Now, the system, or at least the schematic, breaks down a little bit when we're talking about MS because it oversimplifies the good guys and the bad guys, the invaders and the defenders. When we're talking about multiple sclerosis, it's all the same system. And that is what makes it so tricky, particularly when we're talking about medications, because it is all one system, and we don't have a medication that only targets the MS dysfunctioning part. We have medications that affect the whole immune system in different ways. So now that I've sort of set that stage with this analogy and, what is congruent and incongruent with actual life, let me tell you a little bit more about how some of our medicines affect the immune system. So again, we know MS is a disease of altered immune system function. So the medicines that we use are going to target the immune system. But by doing so, they can affect not only the erroneous, the attacking part of the MS immune system, but the other parts as well. So the terminology is varied, but it matters. So we're going to use immunocompromised in its truest sense, which means a weakened immune system. All the pieces and parts are there. They're just not strong. They're not working at their peak performance. Immunodeficiency refers to one part of the immune system not working or just not there. This comes up a lot when we're talking about our anti-CD20, our anti-B cell therapies, and we'll get more into that in a little bit. Immunosuppression is the term that we use to describe just slowing down the immune system. So all the pieces and parts are there, but they're all moving slowly. So in our castle analogy, maybe if we had a river between the invaders and the defenders, this would be slowing things down. We'd still have all the players at work, but they're not moving fast because they have to wade through the river. And then immunomodulation. Again, this means the entire immune system is intact in the sense that all of the pieces and parts are there. But we're modulating the immune system to increase the function of some things, like, for example, more flying dragons, and to decrease others. Maybe we have fewer cavalry, but, 10 times more flying dragons. That's immunomodulating. It means the immune system isn't weakened necessarily, but it's functioning differently. Now, the three that we're going to focus on mostly are these last three: immunodeficiency, immunosuppression, and immunomodulation. And I do want to just take a minute to mention that we're focusing on specifically how these disease modifying therapies, DMTs, affect the immune system. But it isn't just medicines that affect the immune system. Smoking can weaken the immune system. Alcohol, regular alcohol intake, poor nutrition, all of these are things that can also affect immune system function. And so we shouldn't forget those things because they can have an important role in keeping us healthy as well. Now, we're going to say goodbye to my simplistic rendering of our immune system and MS for something that's a little closer to reality, though maybe not as fun. On the left side of this schematic, we have sort of represented the cells of the immune system in the periphery. The periphery means everything that's not the brain, the spinal cord, and the central nervous system, the fluid around it. It's the blood, it's the tissues, everything in our body. Now, how MS is triggered is a complicated topic that we're not going to get into today, but I'm going to simplistically say that it starts in the periphery with immune cells not studying hard enough to learn what they should be attacking and what they should not be attacking. We call this tolerance. Immune cells in the periphery, misguided, not getting programmed the right way. Then for MS, those cells crossing through the blood, across the blood-brain barrier into the central nervous system where they create problems for MS. In this schematic, we see all of the gray boxes have names of disease-modifying therapies, and thankfully there are a bunch. We have lots of options. You'll see that most of the medicines that we use, those gray boxes, affect cells in the periphery. They're not going directly into the brain, though some do. You'll see a couple there. But most of them are making changes to our immune system in the periphery and then having downstream effects in the central nervous system. This is important as we think about our disease mechanisms because we are not able to change the immune system specifically in the way that only affects MS. We can change the immune system in ways that has other effects on the immune system as well. Now, before we dig into which medicines are in which category and why or why not, I want to say if we had a great medicine, worked really well, and had no risk, everybody would be on that medicine. The truth is a little trickier, that we have very good high efficacy medicines that work very well, but may have a high risk profile and often do. And we've got low efficacy medicines, which oftentimes have a low risk profile. The best medicine would have no risk and be working perfectly, but we're not there yet. Historically, how we treated MS, the larger we, was to start with a low efficacy medicine, a medicine that didn't work all that well, but had low risk, and then wait for it to fail. So wait for disease to break through, to present while on that medicine, and then choose a medicine that's a little bit better, and then choose a medicine that's a little bit better, and so forth. The escalation approach. What we know now is that in the very beginning of disease, when all of those misprogrammed immune cells are coming across the blood-brain barrier into the central nervous system, that is the time in the disease when we really need to have a high efficacy drug, a drug that's working really well. So our thinking about how and when to use these high efficacy medicines is changing so that more and more we are using high efficacy medicines early and then maybe stepping down later, but acknowledging that there are risks associated with these medicines that we need to manage and help our patients with along the way. So let's talk a little bit more about immunomodulating therapies. Now, remember, immunomodulating therapies are the ones where you have all the parts of the immune system in place, but maybe you've got some more flying dragons and fewer cavalry or vice versa. These are some of the medicines that fall within that category. They are medicines that, for the most part, have been around a little while. They have low risk, particularly when it comes to infection. Now, there are other risks associated with these medicines, but pertinent to infections, they have a relatively low infection rate. And that is because they aren't suppressing, they're not slowing down the immune system. They are just upregulating some things, down-regulating others. So the infection risk of these immunomodulating therapies is relatively small. Now, there's an asterisk with teriflunomide because that one could be in more than one category, and it does result in some depletion of immune cells, especially in the beginning. But we're going to keep it in this category for now since it mostly is an immunomodulator. Now, disease modifying therapies or DMTs that interfere with trafficking are the ones that kind of slow things down. They include the fingolimod, ozanimod, siponimod family of medicines. They work by trapping lymphocytes within the lymph nodes, kind of just locking the door. They can't get out. They therefore are decreasing the number of lymphocytes in the periphery that are even available to cross into the central nervous system and cause problems. And I do want to say I'm oversimplifying things a bit, but this is in general what they do. And also within this category is natalizumab. Natalizumab has a mechanism in which it kind of shuts the door of the blood-brain barrier so that activated cells, activated lymphocytes in particular, can't cross from the blood into the blood-brain barrier. So it's limiting trafficking. It's just kind of shutting the door, not letting those misprogrammed cells get into the CNS to cause problems. These are cells that probably would fall within that category of immunosuppression, like slowing things down, although with natalizumab, it slows it pretty well. But they are not depleting any particular part of the immune system wholly. That is unlike these next medications that fall within the immune depleting category. These are medicines that really are targeted and specifically decrease one particular area of the immune system. Now, of these five, the three that we use far more commonly in clinic are the rituximab, ocrelizumab, and ofatumumab category. These are drugs that specifically target B lymphocytes and just kind of take them out of circulation. They're gone. This is a very effective mechanism for treating multiple sclerosis, but it does weaken the immune system in the way that those B cells, which ordinarily would be providing good and helpful function as well, they're gone. Now, the rest of the immune system, which is very complex, is still there and doing its thing, but it's not functioning the same without those cells. So, in real life, what does this look like? This is a graph taken from a study that was published recently, but from data that came before the COVID pandemic, where a entire country, Sweden, collected all of the information about the MS patients in that country and the medicine they were on, and whether or not they had had a severe infection, which for this purpose was described as an infection requiring hospitalization. The pink line that you see on the top represents normal general population, indicating that some people over time are going to have a serious infection that requires hospitalization without even taking into account MS or any MS medicines. But then with each of the lines below, you can see they represent patients on that particular disease modifying therapy and show the proportion with no serious infections over time. So we can see that each one of those lines represents more infections over time than the healthy population. But the line with the most infections is the rituximab line. So this would imply that there is a greater risk of infection with patients on rituximab than those other disease modifying therapies represented by those lines. Now, again, a couple disclaimers. This is just one country. It is before the COVID pandemic, but it does give us an idea that maybe there is an increased risk to depleting B cells with medicines like rituximab. Now, let's talk through some more specific examples. So I've mentioned progressive multifocal leukoencephalopathy, or PML for short. This is a central nervous system infection caused by the JC virus, and we see that there are disease-modifying therapies that carry a different risk for this bad infection. The medicine with the highest risk of PML but still relatively low risk, is natalizumab. And then you see there's a category of intermediate risk. You can see those medications there, and then low risk, those medicines listed there. Now, risk is a tricky thing. And for some people, they would say, oh, 1 to 1,000, that's not a big risk. But for another person, that might be a really big risk. What we know particularly pertinent to this situation and natalizumab is that risk can be further subcategorized by whether or not you have a certain amount of the JC virus antibody in your blood, whether or not you've been on prior immunosuppressants, and how long you've been on the medicine. And so, when taking all of these factors into account, we can really customize for this particular drug what the actual risk of a brain infection from PML might be. And this is helpful information when discussing disease modifying therapies and assessing each person's risk tolerance. Now, next, this is a topic that has been well discussed in prior sessions over the last 3 years. But I do just want to touch on COVID infections specifically as it relates to this discussion about disease modifying therapies. So, what we know about COVID and MS is that the risk factors for severe disease, for the most part, don't have anything to do with disease modifying therapy. So, older age, higher disability, previous cardiac disease, obesity, and interestingly, at least in early series, the risk of COVID serious infection seemed higher among people with MS who were not on disease modifying therapy than those that were on disease modifying therapy. Now, subsequent registries, big collections of data have shown that there probably is an increased risk to patients who are on B cell depleting therapy of having serious infection from COVID. So this is something that is very important, again, in considering the risk benefit of these agents across all of them, and weighing the benefits as well. We also know that the risk of severe COVID infection is greater after the use of high dose corticosteroids, like those that we would use for treating a relapse. So, again, these are all factors to keep in mind as we think overall about risk of infection with disease modifying therapies. So, what can be done? Well, in the beginning, or at any time that the patient is considering changing a medicine, having a forthright discussion with your MS doctor about what issues pertinent to you might increase or decrease your risk in any category is paramount. Pharmacovigilance is a fancy word for paying attention. So when somebody is on a medicine that has a high risk profile, you need to pay attention. If it's a patient on natalizumab, you need to be checking the JC virus antibody titer. If you're on dimethyl fumarate, fingolimod, you need to be checking those lymphocytes, those white blood cells over time to make sure they're not drifting too low. We need to be paying attention and respecting the risk that each medicine brings, and then doing everything that we can to keep our patients and ourselves healthy, including vaccination against preventable diseases. So, these are my thoughts about managing risk if you are on a medium to high disease modifying therapy risk medicine. Only my thoughts. 1, 3-hour flight, probably good idea to wear a mask. Licking your fingers after riding the train at DIA, not a good idea. Pack some sanitizer, use it when in those crowded situations. Grocery shopping without a mask, probably okay, but it would be better to have a mask. And outdoor concert, totally fine, low risk. indoor concert. Now we are in October, and that's going to be more and more a reality. I think this is risky given the cold, which includes COVID and flu season. That's a risky thing. I'd wear a mask at least or reconsider. Now, I hope that has helped to answer the question for you or your loved one, am I immunocompromised? I know it's a complicated answer. I'd love to give you something straightforward, but we know that there are many factors that go into that answer. And I hope that this has given you something to think about and something to talk with your MS provider about. Thank you for your attention.